Reimagining Course Curricula for Medical Students by Crystal Weaver. According to Rovner, 2016, doctors in training learn excessive amounts regarding the workings of the human body during medical school and residency, but many are taught next to nothing about the workings of the United States healthcare system. For example, while the St. Louis University School of Medicine and the Washington University School of Medicine provide courses to students regarding healthcare quality improvement, healthcare ethics, and electronic medical information management, there are no courses in the curriculum specifically dedicated to understanding patient health insurance coverage. The United States Centers for Medicare and Medicaid Services 2018 stated insurance plans can differ in which providers the patient can see and how much the patient has to pay. It is essential to understand the costs and key health insurance terms to know what services the patient's plan will pay for and how much each visit or medication will cost. According to Abelson, 4 of 10 Americans delayed medical care in 2022 due to cost. Unfortunately, delays in care may increase morbidity and mortality risk. Assisting medical students with understanding the complex United States health insurance system can minimize delays in care and improve patient outcomes. Therefore, this final project focuses on rethinking and reimagining course curricula for medical schools in the United States. The curriculum reform will emphasize providing third and fourth year medical students with practical applications to better appreciate health insurance policies, including Medicare, Medicaid, and private insurance. In addition, the curriculum will focus on understanding basic health insurance terminology, such as copayment, coinsurance, deductible, and premium. According to Buga 2020, from a structural standpoint, medical education in the United States is rigid. There is a set path those aspiring to practice medicine must follow to obtain a license to practice. Before proposing a change to the rigid medical education structure, one must complete a brief analysis focused on the history of medical education in the United States and previous research studies examining the potential need for curricula changes at medical schools to improve student comprehension of health insurance policies. In the 1600s, individuals residing in North America predominantly depended on self-taught practitioners to provide medical care. Rural communities often utilized plant-based remedies, and treatments rarely involved evidence-based practices. In the 1700s, physicians trained in Europe made their way to the colonies. They settled in urban areas, charging hefty fees for those who were sick and dying. The physicians also implemented self-taught remedies, and little evidence exists regarding the benefits of the treatments. In the mid-1800s, the American Medical Association, or AMA, was founded with an initial focus on data collection of births and deaths in the United States. In 1847, the AMA also began to emphasize improving public health, thus leading to the creation of the Association of American Medical Colleges, or AAMC. During this time, medical schools' curricula were less rigorous than today's standards. Students only engaged in readings and were not required to complete exams to demonstrate proficiency in the subject matter. In the early 1900s, the AAMC announced medical schools would need to provide evidence of a 4,000-hour curriculum to be considered accredited institutions. While the requirement allowed medical schools to develop comprehensive syllabi, the change limited students' ability to develop a medical specialty. Therefore, opponents of the new accreditation standards from the AAMC developed alternative structures, allowing for uniformity and specialization opportunities. For example, Abraham Flexner proposed a curriculum with 2 years of classroom training and 2 years of elective or core clinical experiences. Today, Flexner's curriculum is the structural standard implemented by medical schools in the United States. Currently, 154 medical schools in the United States offer a Doctor of Medicine or MD degree. In addition, 38 higher education institutions offer a Doctor of Osteopathic Medicine or DO degree. MDs and DOs are fully licensed physicians in the United States, trained in diagnostics and the treatment of illnesses. MDs and DOs can prescribe medications, and both degrees require students to complete accredited medical residencies. While MD and DO degrees may appear comprehensive, gaps in the curriculum still need to be addressed. For example, Agrawal and colleagues, 2005, examined medical students' knowledge of central issues in the United States healthcare system and perceptions of the importance and quality of health policy curriculum at medical schools. Results from the study indicated 40% of medical students underestimated the number of uninsured patients in the United States. 32% of medical students were not aware the United States does not have the highest life expectancy in the world. And 27% of students were not aware the United States has the highest health cost per person in the world. The researchers concluded medical students have significant gaps in knowledge concerning the United States healthcare system. In addition, most students perceived the deficiencies were not adequately addressed during the medical school curriculum. Riegelman, 2006, reported the Clinical Prevention and Population Health Curriculum Framework of the Healthy People Curriculum Task Force recommended a health systems and health policy curriculum for medical students, which included the domains of organization of clinical and public health systems, health services financing, health workforce, and health policy process. Unfortunately, only 40% of medical schools in the United States include the domains in their required curriculum. Critics of adding health policy curriculum cite the already excessive length of medical training in the United States as a basis of opposition. Currently, the average length of medical training is 14 years past high school. Adding health policy curriculum of any kind could further lengthen the process. Therefore, to ensure medical students receive proper training regarding United States health insurance practices to better serve patients, the curriculum reform must be comprehensive and accurate, but not lengthen the training process. Reforms must be implemented into pre-existing pedagogies. Reimagining curricula to ensure medical students receive proper training regarding health insurance practices may occur during the 3rd and 4th years of medical school. Typically, medical students engage in clinical rotations, also called clerkships, during the 3rd and 4th years of medical school. Rotations provide students firsthand experience working with patients in various specialties under the direct supervision of a faculty member, fellow, resident, or attending physician. During clerkships, medical students often engage in a practice known as rounding. According to Begzada, 2021, clinical rounds provide opportunities for medical students to acquire essential skills to practice medicine in the real world. While healthcare institutions frequently implement interdisciplinary structures, currently, rounding with medical students predominantly only focuses on instruction from physicians. During rounds, medical students visit each patient as a group with the physician to review patient status and care plans. Sharing observations and asking questions during rounds can generate valuable information and insights which can positively influence treatment and care planning. What if rounding during clerkships was not simply led by a physician, but also incorporated the expertise of a health administrator and social worker? During each patient visit, students could converse with the physician regarding the patient's medical needs and speak with a health administrator or social worker regarding the patient's healthcare coverage and any financial challenges that may result from medical care. In addition, the students could converse with the health administrator and social worker to better appreciate how any financial challenges can be appropriately addressed by the healthcare interdisciplinary team. Educating medical students regarding healthcare expenses during the rounding process allows students to fully appreciate the concept that while treatment decisions and modalities are needed to improve patient physical health, many times a financial burden to patients results from the process. To engage in best practice, medical students need to connect and empathize with patients to better appreciate how stress and anxiety levels can increase due to the financial burdens associated with treatment. Let's review a hypothetical case to better appreciate the reimagined process. Patient A has been admitted to the hospital to begin treatment for a cancer diagnosis. According to National Comprehensive Cancer Network, or NCCN guidelines, the patient should immediately begin chemotherapy treatments. During the rounding process, the physician reviews the NCCN guidelines with the medical students and engages with students regarding the potential side effects associated with treatment. After this initial process is complete, an additional layer is added. The social worker and health administrator review with the medical students the financial challenges associated with the treatment modality and interventions to potentially mitigate the financial challenges. For example, the health administrator can engage with students regarding the differences between copayments, deductibles, and out of pocket maximums associated with the patient's health insurance policy. In addition, the administrator can provide a basic overview of the billing and coding processes that ultimately trigger payment for treatment. Furthermore, the social worker can engage with students regarding potential nonprofits, such as cancer care, to assist the patient with the monetary expenses associated with the deductibles and out of pocket maximums. It is important to note the reimagined educational process does not encourage medical students to practice outside of the physician skill set. Medical students are not expected to identify as social workers or health administrators. Medical students are simply asked to better appreciate the complexities of the United States health insurance system and obtain a basic understanding of how to assist patients with successfully maneuvering through the system. In addition, medical students should appreciate that each treatment decision can not only have long-term physical consequences for the patient, but also long-term financial consequences. According to the AAMC 2023, all medical schools share the goal of preparing students for residency training and practicing medicine. An essential component of the training should include improving student comprehension of the health insurance practices in the United States. By reimagining rounding processes during clerkships for third and fourth year medical students, this goal may be achieved, thus improving medical student competence and patient outcomes.